Hello guys, and today we are going to discuss about diabetes insipidus. It's a pathologic condition related to the kidneys, as the name suggests that it's diabetes insipidus, right? It is a condition characterized by polyuria, nocturia, and it is due to the deficiency of antidiuretic hormone. And we will see that how this deficiency is occurring. So, in diabetes insipidus, there will be polyuria, and some textbooks suggest that polyuria can be more than 20 liters per day. And it's a huge amount, 20 liters per day, but most of the patients complain of the polyuria more than 3 liters per day. Okay, this was for polyuria. The second is the nocturia. Nocturia means that the patient has to wake up at during the sleep at night and he or she has to use the washroom, right? It's nocturia. In case of pediatrics, we can say that it's nocturnal enuresis. Nocturnal enuresis means bedwetting. The pediatric age group, like children, they wet the bed, right, at the night mostly. So it's the condition related to the diabetes insipidus. There are two types of diabetes insipidus. The first is the central diabetes insipidus, and the second is the nephrogenic diabetes insipidus. First of all, we'll discuss about the central diabetes insipidus. What is included in this? It is the damage to the posterior pituitary, gland, right? Damage to posterior pituitary or hypothalamus. It will disturb the pituitary hypophyseal axis, right? It's posterior pituitary damage, or it can be damaged to the hypothalamus. As you know that antidiuretic hormone is released from the posterior pituitary, right? So if the part of the posterior pituitary is damaged, so how antidiuretic hormone is gonna secrete it? And there are some conditions why there is damage to the posterior pituitary. It can be tumor, right? It can be tumor to the brain. It can be benign or malignant tumor. The second is the post cranial surgery, means that the patient has undergone a cranial surgery procedure, post cranial surgery. So that's why the part of the pituitary gland is being disrupted. And it can be head injury, like for example, if the football has hit the head of a patient, head injury can be included in the trauma, right? Head injury. There are several important granulomatous conditions. I will highlight them. There are several granulomatous conditions, right? Granulomatous conditions. And granulomatous conditions include two important conditions, which are sarcoidosis. And for the definition of sarcoidosis, I need you to write down that it's disease in which there are small patches of swollen tissues called granuloma that develop in different organs of the body. I'm not writing the definition, but just for you to understand, this sarcoidosis is a granulomatous condition in which small patches of swollen tissue, which is known as granulomata or granuloma, they accumulate in different organs of the body. And the second granulomatous condition is histiocytosis. And histiocytosis is nothing but abnormal number of WBCs. Abnormal number of WBCs, known as histiocytes, they starts to accumulate in different parts of the body. And in case of sarcoidosis and histiocytosis, they both accumulate in the brain part, that is hypothalamus and pituitary, and they can hinder in the secretion of antidiuretic hormone. And the next etiological factor can be AV malformation. Okay, it can be AV malformation in the brain. What is AV malformation? AV malformation is a tangled network of blood vessels that connect artery directly towards the veins, and they're bypassing the normal capillaries, right? And the other etiological condition is known as Sheehan syndrome. What is Sheehan syndrome? And it's like really peculiar. So let's discuss about it. Sheehan syndrome is postpartum hypopituitarism. I will write it down for you. It's postpartum. It means that after the delivery or after the child included in the etiological part of the central diabetes insipidus. The second is the nephrogenic type of the diabetes insipidus. And in the nephrogenic type, it's very important to understand that in nephrogenic type, the V2 receptor in the nephrons, V2 receptors are those receptors on which the antidiuretic hormone act. These V2 receptor in the nephron become resistant to antidiuretic hormone. Although in case of nephrogenic diabetes insipidus, the amount of antidiuretic hormone in the blood is high. In spite the adequate amount of antidiuretic hormone in the blood, still the V2 receptor are not responding to the antidiuretic hormone, and there can be conditions due to which V2 receptors are not responding. There are some also etiological factors. They can be drug toxicity. The drugs, there are two names indicated here. First is the lithium. Like lithium toxicity can lead to V2 receptor resistance, and the second is the amphotericin B. Amphotericin B is not very important, but lithium is certainly important. Amphotericin B. Okay, there are two drugs which you need to mention in case of nephrogenic diabetes insipidus. The second important cause for the V2 resistance is hypercalcemia, and it's very important because when there is high level of calcium in the blood or in the tubules of the nephron, ultimately this calcium is going to be filtered, and this calcium is gonna inhibit the aquaporin too. You know that in case of principal cells, when antidiuretic hormone act on these cells, they cause the installment of aquaporin 2 on the luminal membrane. So hypercalcemia will inhibit the aquaporins 2 to be installed in the luminal membrane. So it inhibits the water reabsorption. Ultimately, it will inhibit the antidiuretic hormone function. The second is the sickle cell anemia. But how sickle cell anemia is going to cause nephrogenic diabetes insipidus? You know that in case of sickle cell anemia, the RBCs become sickle shape, right? They become sickle shape, and you know that there are specialized type of vessels known as vasa recta. Vasa recta are important for supplying the medulla of the kidney, and when the sickle cell shaped RBCs pass through the vasa recta, they are going to block the vasa recta, right? And the part of the medulla which was supplied by the vasa recta undergoes ischemia and infarction. So that's why they they cause ischemia of the medullary region. So that is the function, or that is the negative function of sickle cell anemia. The last but not the least condition in case of nephrogenic type is amyloidosis, in which the amyloid protein is going to be deposited in the nephron, and it's going to inhibit the function of ADH. This was for nephrogenic diabetes insipidus. So what will the workup or investigation part for these patients? What is the workup for such patients? Because they are passing huge amount of urine, they are manifesting polyuria, they are manifesting polydipsia, they are manifesting nocturia. So what is the workup for such patients? The workup, we need to check the 24-hour urine collection, right? In such patients, we ask the patient to collect their 24-hour urine in order to check the amount of the urine. Okay, is the patient is having polyuria or not? And we need to check the urine quantity as well as the quality as well as the electrolyte composition of the urine. The second is that when the patient is passing a huge amount of urine, the urine contains water, right? So the urine osmolality in this condition will be less because huge amount of water is present in the urine and the urine is diluted. In case of polyuria, diabetes insipidus, the urine is diluted. And what about the plasma osmolality? The plasma osmolality will increase. Plasma osmolality will increase because plasma is concentrated in such patients. It is concentrated and the plasma osmolality is certainly increased because antidiuretic hormone is not functioning. There will be huge amount of water loss from the body, so plasma volume and plasma osmolality starts to increase and plasma volume starts to decrease. And in case of the concentration of antidiuretic hormone, what do you think? Antidiuretic hormone in the blood is high or low? Antidiuretic hormone is in adequate amount in case of nephrogenic type, in case of nephrogenic type, and in case of central type, because there is damage to the posterior pituitary, the antidiuretic hormone is in low amount in the blood in case of central type of diabetes insipidus. So this is worth mentioning here as well. There's a special type of test known as the Miller-Moses test. It is of certainly great importance. Miller-Moses test. And so let's discuss what is Miller-Moses test. It is very, I will simplify for you that in the Miller-Moses test, in a healthy individual, we are not talking about the diabetic insipidus patient, we are talking in healthy individual. We will cause the patient to drink large amount of water. We will cause the patient not to drink water, right? We will cause the patient to become water deprived. Water deprivation is there. Deprivation is there, right? And when the patient or when a normal person, that is healthy individual, is not drinking, not in drinking even a single glass of water in a whole day, so the person became water deprived. And in the healthy individuals, the urine concentration or urine osmolality of such patients become 4 times more than the plasma osmolality because urine became more concentrated here. We are not offering the patient or a person even a glass of water, so the person became water deprived, and in this condition the urine osmolality is going to increase 4 times than the plasma osmolality. But what do you think in case of diabetes insipidus patients, this type of urine concentration is possible or not? Because there is no function of antidiuretic hormone, we cannot concentrate the urine. The antidiuretic hormone function is to reabsorb water from the lumen of the tubules. In case of diabetes insipidus patients, the antidiuretic hormone is not functioning, so this urine concentration is not possible. Urine concentration isn't possible in case of diabetes insipidus. It's not possible because of the defect in either secretion or either the V2 receptor resistant, the ADH function is inhibited in either the cases, right? So this type of urine concentration is not possible in DI patients. Other type of investigation or workup for such patient is MRI. MRI is known as magnetic resonance imaging, but there is a special type of MRI known as the track weighted imaging. The track weighted imaging, when we do MRI TWI, that is magnetic resonance imaging, track weighted imaging, it's a subtype of MRI, right? So when we do this technique to the diabetes insipidus patient, but when we do in a normal patient, let's talk about in the normal healthy individual. The posterior pituitary posterior pituitary part will release a hyper intense signal, right? Posterior pituitary will release hyper intense signal in case of this technique, hyper intense signal. But in case of diabetes insipidus, this type of hyper intense signal is absent, and here is the diagnostic criteria for the DI patients. When we do this technique in normal patients or normal persons, they do not have diabetes insipidus, there will be presence of hyperintense signal. But in case of the patients with diabetes insipidus, the hyperintense signal is gonna absent. Let's talk about finally the treatment part of diabetes insipidus. The treatment include for two types respectively, the central diabetes insipidus and the nephrogenic type. First of all, we'll discuss about the central type of diabetes insipidus. In the central type, the drug of choice or the first line drug is known as desmopressin. And why we use desmopressin in such patients? Because desmopressin will act as the V2 receptor. It will act as the V2 receptor and it's gonna reabsorb the water and it will prevent polyuria and the patient may stabilize, right? But for the administration of desmopressin, it is not recommended in the form of nasal spray, because in the nasal spray it's gonna act instantly and it is very dangerous for the patients. Why it is dangerous? Because desmopressin is gonna act on the V2 receptor. It will cause manifestations like antidiuretic hormone. Although ADH is not there, if we administer the desmopressin via the nasal spray, the result will instantly increase and there will be manifestations like SIADH. What is SIADH? SIADH is the syndrome of inappropriate antidiuretic hormone secretion, and desmopressin, when given instantly, it will manifest the conditions like SIADH. And one of the condition is of SIADH is hyponatremia. Why there is hyponatremia? Because the water will quickly be reabsorbed from the collecting tubule, the plasma volume will rise, and the sodium in the blood starts to become low. It is relative hyponatremia, right? Because of the increase in the plasma volume. And this is, we can say it is relative hyponatremia, or we can say it is dilutional hyponatremia. The other drug for the central type of diabetes insipidus can be carbamazepine. It's carbamazepine, and carbamazepine function is to release of ADH. It will cause the release of antidiuretic hormone, although it's not the drug of choice, but still it's gonna help the patients with diabetes insipidus. We have discussed the central type treatment. Let's talk about the treatment for the nephrogenic type. In case of nephrogenic type, you will be astonished that we are going to use diuretics like thiazides. And you will question that thiazide, already the patient is suffering from polyuria, water loss, the salt loss. Why we are using thiazide? Because thiazide function is to cause the blockage of the sodium chloride channel in the distal part of the nephron. It is inhibited and there will be polyuria, salt loss, right? But in case of diabetes insipidus, already the patient is suffering from polyuria. Why we are using thiazide in such conditions? Because initially It seems that thiazide is not to be administered in such patients. When we give thiazide initially, it will cause water loss. It will certainly cause water loss and the salt loss, but in the long run, we are administering this drug in the long run, we will see that it will upregulate the cells of the proximal convoluted tubule to reabsorb maximum amount of water, right? We are not even allowing the water to reach the distal part of the nephron on which the thiazide is reacting, right? PCT will reabsorb maximum amount of water. So when the water has been maximally reabsorbed in the proximal convoluted tubule, much less water is reaching the distal part of the nephron. So thiazide is basically upregulating the proximal convoluted tubule cells to reabsorb maximum amount of water that is needed for the patient, right? So in the long run, thiazide is definitely a drug of choice in case of nephrogenic type. When we are using thiazide, there will be hypokalemia because due to the RAS activation, there will be hypokalemia. So we can give amiloride. Amiloride is a potassium sparing diuretic, and along with the thiazide we can use amiloride as to inhibit the potassium loss in such patients. The next drug of choice in case of nephrogenic type is indomethacin. Why we are using indomethacin in case of diabetes insipidus? Indomethacin will block the COX. What is COX? It is cyclooxygenase, and cyclooxygenase will cause the conversion of arachidonic acid to prostaglandins. Basically, in case of indomethacin, we are blocking the production of prostaglandins. And you know that prostaglandin is a vasodilator. Prostaglandin is a vasodilator of afferent arteriole. It is a vasodilator of afferent arteriole, and under the action of prostaglandins, the afferent arterioles dilate and it will increase the GFR. But in case of patients with diabetes insipidus, we do not want to increase the GFR because it will cause water loss and salt loss from the body. So we have used the drug known as indomethacin. It will block the production of prostaglandins by blocking the COX. So its vasodilating effect will be decreased and GFR will decreased. In this condition, there will be less water, less filtration, and less GFR and less water and salt subsequently lost from the body. This was for diabetes insipidus.